All right, everybody. Good afternoon. Good afternoon. So welcome to this Funday with Joe. So as I always tell everybody, it doesn't get any better than this, guys. You're in my garage with me, and this is where I do all my little teaching magic right here. Again, for those of you guys haven't seen my garage, let me introduce you to it. So here I am. Over there, right? That's my kegerator right there, right? That's got Pacifico in it. Then, of course, that's got all types of good drinks there. And, of course, there's my golf clubs sitting right there, big into, I'm sorry. There they are right there. My golf clubs, workout stuff. So this is it, guys. You're in my garage. So this is as good as it gets. So today what we're going to do is we're going to do osteomyelitis and meningitis. And what we're going to do is kind of keep it high value, right? Because I know, like, when you read up on the books, that sometimes you almost feel almost overwhelmed with all of it. So it kind of doesn't make. So we're gonna, you did it your way. And how was that? Well, you memorized things, didn't you? And then you took an exam, and then someone says, "Hey, which antibiotics you want to start?" And you're like, "Oh my God, let me go look it up." So we're gonna do this a little differently, guys. Okay, we're gonna do it, as I would say, we're gonna do it my way. Okay, so let me share my screen with you. Okay, and then let me pull up, right? So let me pull up the meningitis osteomyelitis. Okay, so this page is worth its weight, and it's just literally worth its weight in gold, right? Because this has so much information on it. And I'll make sure that, Stefan posts it up on the site. So if you guys want to go get it, you can. So let's go over the basics, okay? Just the basics, right? Okay, so we'll do meningitis first, right? So this is what we'll do. We'll do meningitis first. So what's the most common cause in neonates? All right, so this is group B strep. So, right, I always say people learned it at school. What does group B strep stand for, right? B stands for button babies, right? So where's group B? When it's close to the button. What does group B deal with? Well, don't want to have babies exposed to it. So group B strep is part of that prenatal visit, right? For moms, when they're at 32, 36 weeks, we swab. And just to make sure that if she's positive, then obviously we treat her, because the last thing we want Junior to do is get exposed to group B strep. One of the things you'll see, guys, is we talk about this bacteria in such an ambiguous term, like, oh, group B strep, button babies, ha, ha, ha. Trust me, it is a lethal bacteria. And have I seen it? Yes. I still have this one case. I'm telling you, it scarred me, to be honest with you. It was this young guy. He was 26 years old. He was a rower, so he was on the rowing team, right? Real big guy. And I mean, the guy looked like Hercules, to be honest with you, right? He had this big bicephalic vein and big biceps and everything. So he came in for anxiety. And of course, as he was there, he just started to decompensate. So we ended up doing a lumbar puncture. He grew up group B strep. Guys, he died in 24 hours. Yep. A healthy 26-year-old, 0% body fat, looked like Hercules, was dead in 24 hours with this stuff. That's how lethal this is. Got it? And then that commercial that you see out there, right, about the kid going to college, and they talk about this new vaccine for meningitis. They're going, only accounts for maybe 5-10% of the time. This is what they're saying. They're saying, hey, vaccinate your college kids before they go to school with group B strep. And this is exactly what we do with these people, right? So just, food for thought. This is just a really nasty bacteria. And then there it is. Listeria. All right, guys. I want you to get to know this bacteria, because you'll see this on all the test questions, and they really are trying to jack you up on this one, right? And I've always say, right, when they try to jack you up, what do? Well, we jack them back, right? So Listeria is this bimodal bacteria. It shows up when I'm really young, and it shows up as I get older. So it's bimodal. Got it? It's two different areas. It's like, okay, so I'm going to hit you when I'm young, and I'm going to hit you when you get older. Exactly. And so what's the antibiotic of choice when we deal with Listeria, guys, is ampicillin. So AMP is covering Listeria. You got it? So you're like, okay. And you see how this is part of the regimen? So AMP is causing Listeria. So when I've got a neonate, what am I going to do? Well, the AMP's going. The question is, who's driving the car? There's sulfoxetine. This is the one that we commonly use. So when you're on the boards and you're lost and on the boards, and they give you an antibiotic regimen, what do you like? It's like, Joe, I like combo meals. Exactly. We all like combo meals. Come on. When you go to McDonald's, Burger King, you go to Raising Cane, what do you get? I get a combo meal. Exactly. So guess what you do when you start treating bacteria? I give a combo meal if they're going to be admitted. Heck yeah. And so this is what we do. Okay. So most common cause of meningitis in neonates, group B strep. Who's in the back seat? Listeria. And what am I going to have to put in the back seat to cover for listeria? Ampicillin. Does everybody see this? So you'll see this on the test question. You'll see this in Hippo. You'll see this in Roche. You'll see this in UWorld. You'll see this in Kaplan. You'll see it in all. And they always kind of slide this one in. And this is obviously where the students get it wrong. After 3 months of age, so we can argue 1 to 2 months of age. We can have this academic argument about who's coming. But usually what they'll do is they won't give you that. They'll give you something else. So once they get to 3 months of age and older, what is the most common form of meningitis? It's strep pneumoniae, strep pneumoniae, strep pneumoniae. And guess what it is again? That's right, strep pneumoniae. So what's the most common form of meningitis after 3 months of age? You walk the earth as a Homo sapien bipedal, 23 sets of chromosomes. What's your answer? Strep pneumoniae. How do I treat meningitis after 3 months of age? Okay, where do I really go? Like I said, we can get this argument below it. It's vancomycin, 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 vancomycin. Hey guys, guess what it is here? Vancomycin. But then you're smart enough to know, wait a second, Joe. He's getting older. So who's in the back seat again? Listeria. I'm still giving vancomycin, but what do I have to cover him with? Ampicillin. And that's exactly what we do here, guys. That's exactly what we do. Okay, does that make sense to everybody? So I hope that makes more sense to you. Okay, so on the boards, got it? On the boards, what's the most common form of meningitis? Pierce. So they're going to be ambiguous with you, right? So what's the most common form of meningitis? And you're like, oh, it's going to be strep pneumoniae. Now, when they start giving you age, this is where they're challenging you. This is where they're challenging you. So if I got the neonate, what's my neonate got? Oh, it's got group B strep. And who's in the back seat? Oh, listeria. But after that, got it? So we'll just get into like, maybe 6 months and older, right? Oh, it's strep pneumonia all the way. When does listeria go back into the back seat? Oh, greater than 50. So what do you give him? Vancomycin, but he's greater than 50. You're like, oh, well, then I need to throw in AMP. Got it? So this is what we're talking about. All right, does that make sense to everybody? And one of the things you'll see out in the real world is sometimes when we use Rocephin, you'll see this other medication come across the board called cefepime. So cefepime is another really strong antibiotic that's a good substitute for Rocephin. So if Rocephin's not there, oh, I'm gonna look for cefepime. Yeah, it's a good drug. It's a great drug. So like if you come to the work, you come to work with me in the ER, right? So I was at work last night and you get like those sepsis of unknown origin. Guess what we throw them at them, guys? We throw Vanco and cefepime. Does everybody see this? So we know this covers a good broad coverage. He's got him covered. Now, what's he growing? I don't know. We'll see what the blood cultures show, these sepsis of unknown origin. Okay, so now does everybody see where these test questions come from? Get it? So does everybody see this? And then, so we all know that, okay, so when listeria shows up, what do we throw? AMP. Then comes the question about what's the most contagious form. Okay, that's Neisseria. So this is where they try to confuse you. See, when I've got Neisseria, you're right. I can get pretty septic and I got that rash, right? So they'll talk about this rash. He's got it on his hands and his legs. He's altered, has a high fever, stiff neck. What do you think? And does everybody see this? Okay, this is what this is going to be, right? So this is going to be the Neisseria, right? And then prophylactically, so let's just say you're the PA, did the spinal tap, right? Homeless guy, something, he's got Neisseria. So what happens? Well, the nurse, the epidemiologist calls you the next day, don't they? They say, hey, Joe, remember that guy in bed 2? Yeah. Well, he's positive for Neisseria. You're like, all right. And so what does she want you to be on? Either Cipro or Rifampin. So they put one or the other. They cannot put them both on the same page. Got it? All right, so that makes sense. So as a recap, just as a recap, got it? Recap. Most common cause, meningitis. What is it? Group B strep. Who's in the back seat? Listeria. What am I going to give for the group B strep? Sulfoxetine. That's a good drug, sure. But what are you going to give for listeria? I'm giving AMP. After 3 months of age, like I said, this is getting deep in the weeds, so I can't see them going here because it's just too controversial. When you get here into 1 to 3 months, it's just too controversial. It really is. We can have this academic argument till the cows come home. But after 3 months of age, what's your most common cause? Strep pneumoniae, and strep pneumoniae. What are you giving? I'm giving vancomycin. I'm giving vancomycin. What are you giving? Vancomycin. And then, okay, I'm older than 50. Who's back in the fold? Listeria, what do you have to give? I still give vancomycin, but I'm going to give ampicillin for listeria. Now, does that make sense to everybody? And then they're going to say, what's the most contagious form? Yeah, the most contagious form is going to be Neisseria. And that's one that obviously, like I'm here in California, a lot of the UC systems here, I don't know which state you guys are in, but here in California, the UC systems, they require this vaccination for students to come in and stuff like that. And so this is one thing. But you can remember, what's that new vaccination you see the commercial for? Yeah, Group B strep. And trust me, nasty bacteria. You want nothing to do with this. Got it? I'm telling you, it's just one of the worst bacteria I know is Group B. Group A strep's like, you got a sore throat. Yeah, you might get rheumatic fever, but you're going to walk away. Group B strep, it's going to basically, take, exsanguinate your life out of you. Got it? This is what you don't want to do. All right, so there's the meningitis. Don't worry, we're going to do some questions here in a second. Okay, osteomyelitis. Okay, you walk the earth. You know what the answer is? Staph aureus, Staph aureus, Staph aureus, Staph aureus. And guess what it is tomorrow? Staph aureus. Christmas Day, you know what it is? Staph aureus. How about Super Bowl Sunday? I don't know, Staph aureus, Joe. How about my favorite holiday, Cinco de Mayo? Oh, Staph aureus. For sure. It's staph. So you see, guys, it's always staph. You see, this is where they try to jack you up. Here. Okay. And let's unpack this because there's so much here. So much here. So let's just stop. Let's go down the rabbit hole with Joe. I promise you there's a big, important piece of nugget that we need to go get. We need to get this little nugget. Okay. Sickle cell anemia. So go ahead, guys. Kind of regurgitate in your head. What did you learn about sickle cell? You're like, well, they go into those crises, Joe, and they get that sickle pain, and we give them oxygen, and we give them pain meds, and we give them fluids. What else did I memorize in school? I think something, I don't know, Joe, something about elevated retic count and something about the spleen. Yeah, that's all I remember. You remember anything else? Okay. Perfect. Can we all agree, just foundationally, can we just all agree foundationally that sickle cell damages the spleen? Sickle cell, the disease, not the trait. Got it? Can we all have that foundation agreement? Okay, perfect. Let's keep walking. Guys, if you were to do a biopsy of your spleen, go do them, right? If you were to do a biopsy of the spleen and look at the splenic cells histologically, so you looked under a microscope and said, hey, what are you? What would we find? No, really, give that some thought. What would you find histologically with sickle cell? In the spleen, I'm sorry. What would you find? Guys, it's lymphatics. Guys, you're looking at the largest lymph node of your body. So you need antibodies in bulk, like Costco. You need like bulk antibodies. Who do you call it? The spleen. Okay, throw it in reverse now. Throw it in reverse. Remember mono? Yeah, you're fighting a virus for how long again? 2 months. You think your spleen showed up? Oh yeah, they get splenomegaly, Joe. When people are septic, they're up in the ICU and we know that they're really infected. Guess what they have? Oh, wait a second. My largest lymph node, splenomegaly. Exactly. Okay, throw it in reverse. Hi guys, your spleen doesn't work. Nah, it's out of commission. You've been throwing these little sickle cells in there. Does it work? And now you're going, wait a second, it doesn't work. Exactly. Which means, wait a second, Joe, then I can't make antibodies. Exactly. Which means you're telling me I'm immunocompromised? 150%, I'm telling you compromised. So now does everybody get it? Get back out of the rabbit hole. So now does everybody get it? If you come to, just look at your electronic charting, you'll look at the protocol, guys. When we have sickle cell patients with fever, do they go home? Oh, heck no. Would you send a cancer patient home with the fever? Would you? No, Joe, I wouldn't do it ever. Exactly. So I want you to view your sickle cell disease patients as being on chemotherapy. They have no immune system. They're like zero. And guess who we vaccinate the daylights out of? Sickle cell. Remember when COVID a couple of years ago, we were trying to ration out the vaccinations? Guess who was high on the list? Sickle cell. Just look it up. You want to, guys. It's sitting there. So now does everybody see who sickle cell is? Okay. Salmonella. Believe it or not, look up salmonella, guys. Just look it up. Look up food vectors for salmonella. And I can guarantee you, everybody I'm talking to right now, in the last 2 months, you've been exposed to this. If you went to Chick-fil-A, you had some chicken. I mean, it's everywhere. This is everywhere. Salad dressings, it's in peanut butter. No, look it up. It's in peanut butter. You're like, what? Salmonella and peanut butter? Exactly. It's in salad dressings. I could go on and on and on. Cakes, and just name it. Which means it's a common thing we all get exposed to. Guess who also gets exposed to it? The sickle cell people. But here's the key point. You're a healthy person, so you can have that, Carl's Jr. chicken sandwich, like, oh, my stomach doesn't feel good for a day, right? And you're good to go. But this person doesn't. Now do you get it? It's everywhere, guys. So guess who gets exposed to eating it? Sickle cell. And then here we go. Here they coming to jack you up. You see, guys, if I have sickle cell, what's still my most common bacteria? It's Staph aureus. Guess who's in the back seat as a passenger? Salmonella. So now does everybody see, now we have to change the regimen to where we cover staph. And guess what we have to take care of in the back seat? Sickle cell. And that's exactly what it is. So what's some of the good drugs we use for staph, right? So that's our Vanco, right? Or sometimes nafcillin is another good choice. And then what we'll do is if they're diabetic, right? We know that, their diabetics can grow Pseudomonas really well, right? That's what we know, the diabetics. So what we'll do is add the fluoroquinolone. But one more time, that diabetic patient with the foot ulcer, what's he still growing, guys? Mostly that. But what's in the back seat? Pseudomonas. So does everybody see about who the driver is and who the passenger is? So who's your driver? Staph. Who's in the back seat? Well, if it's a diabetic, it could be Pseudomonas. I got sickle cell. What's back there? Could be Salmonella. Exactly. So what do? Well, if I got staph, okay, I'm going to give the Vanco. Good call. And if he's sickle cell and Salmonella, and you'll see that Salmonella works well with the fluoroquinolones. Or if I'm a diabetic and I'm worried about Pseudomonas, fluoroquinolones. Now, does everybody see this? Okay, does that trying to make more sense, right? So let's go play with this. Okay, so let's go play with our newfound knowledge, right? Let's go play with our newfound knowledge. And so now we all have a kind of an idea about the meningitis. Now we have a good idea about the osteomyelitis. Okay, great. Let's go play. All right, so this is U World, right? This is one of my but for myself, I think it's one of my favorite ones. I like it the best, right? Because I think it really kind of encompasses what the boards is going to be like. Okay, and this is just a little free gift to you. So let me show you how students look at test questions. You ready? Here, I'll play student. So just put me in any PA school there that you're going. So I'm a student at PA school. So how would I read this? I'd go, 66, urinary incontinence, pain, fever. Oh my God. Wow. Lumbar spine, absent deep tendon reflex. Oh my gosh. Oh wow. Claudia Quantis, do MRI. Okay. I tell this to all my high-risk students. I do tutoring through the country, and I always tell them this, and I'll say the same thing to you. You are walking into a jail cell. No, this is your cellmate. No, you do not get to leave the question ever. And how many times in PA school have you taken a question and you added something too because it just made you feel better? You're like, oh, I feel better when I sprinkle a little of this. You're in jail. You don't get to leave. You're stuck with this guy. So how would I break this question down? So I got a 66-year-old guy comes in with diabetes with progressive low back pain. Okay. And he's got urinary incontinence. You're like, oh, that can't be good. Right. And decreased appetite for 2 days. All right. He was recently diagnosed with an L4, L5 herniation and receives an epidural injection. You're like, okay. And I always tell everybody about halfway through the question, stop. No, just stop. So he's 66. He's got urinary incontinence and you gave him an epidural injection. He's febrile. Blood pressure is fine. Pulse is fine. I'm going to leave all that alone. Remember, if it's normal, drop it. The patient is alert and oriented. Okay. Physical exam shows tenderness to palpation of the lumbar spine and absent deep tendon reflexes. Okay. And both lower extremities. Rectal exams. So now you're going, okay. It sounds like something's going on there in the back. So you look at the labs and you're going, okay, so he's got something going on. Can we agree? So look at your cellmate. Stop running out of the room. Look at your cellmate. He's 66, had an epidural injection, and he has a fever, and he's got tenderness over the area. Does everybody see that? You're like, okay, PSA, that makes no sense. Oral antibiotics, he needs IV. Do I want to give him steroids? No. There's your two answers. And I always say, when you get down to those two answers, what do? You stop. You stop what you're doing, okay? Because this is where students go wrong. Right? What do you guys do? And you're going to laugh because you're going to go, man, how well does he know me? This is what students do. They get down to two answers. What do? You go inside your head. And I do. You guys got like this UFC fighting cage, and then you start beating yourself up. Oh, you get in this huge fight, right? And then you get frustrated, and then you come out and you're like, it's this. Okay? Stop fighting yourself. Common sense. Common sense. And one more time, common sense. When I get down to those two answers, I'm going to use common sense. No fighting. Okay, so he's 68, had an epidural injection, and he has a fever. And you're like, maybe he's got an epidural abscess. I don't know. Let's try that. Because he doesn't show signs of meningitis. And there it is. And that's what he has, right? I had a case last night. I was at work last night. Ladies, this is like literally carbon copy of her. Except she was 76. Got it? Or so does everybody see this? So now she's got an epidural abscess, right? So then obviously we need to treat her, right? Okay. Next one. I got a 23-year-old guy. No prior histories of seizures, is brought to the ER department after experiencing a general clonic seizure. You're like, okay, that can't be good. He's a young buck. He's 23. His roommate states that he's had a fever and headache for the past 2 days and has been and is talking nonsensely. You're like, okay, so something's going on. Something's here. The patient has no chronic medical conditions, but he has cold sores in the upper lips for the past few days. So, okay, so you see your patient, you see him, he's 23, just had a seizure, he's had a fever, he's altered, he's got blisters on his lip. Everybody see this? So he's febrile. And let's just say you don't know what this means. You go, Joe, I don't know what swelling of the temporal lobes mean. I don't know. Okay, drop it. So in addition to elevated CSF protein content, so you got to start thinking stuff. So this is when they do that analysis. Okay, guys, common sense. No, just common sense. So he's 23, right? He's got a fever and a headache and cold sores. So you're probably going, Joe, it sounds viral. The cold sores, maybe it's herpes. Okay, I'll go with you. So, okay, so you're a bacteria, right? I mean, you're a virus. Do you eat? No, really, do you eat? You're like, no, I don't eat. I'm a virus. I don't eat, which means my glucose level is going to be normal. Okay, good. See how we knocked out 2? Okay, so you're a virus, right? Correct. So what's going to be elevated? Neutrophils or lymphocytes? You're like, that was lymphocytes, Joe. That makes no sense. Oh, this is here. And then all of a sudden you get caught here. You're like, I didn't know it could increase erythrocyte counts, but this is the only one that's just good enough. It's not 100%, but it's just good enough. All right, I'll take it. And then what you'll see if you read up on viral ones and stuff like that, they can end up causing, right, especially the herpes one, they can get the elevated erythrocytes. Does everybody see this? But does everybody see the common sense we use? See, I've been doing this for so long, guys. I can show you where students go wrong. I mean, low glucose and a viral infection, it's like, I don't know what they're doing here, but they're way off base. And then normal glucose, normal cell count, it's like, no, it's not. It's going to have the elevated lymphocytes. Exactly. I've got a 34-year-old IV drug user, right? Presents to an episode of involuntary right arm twitching that lasted 5 minutes. You're going, okay. I don't see it, but I can see what's going on. He also has weakness of the right arm for the past 2 days. Like, okay. Review system reveals recent headache, blurred vision, and decreased appetite fatigue. So it sounds like he's pretty sick. He had 1 episode of vomiting. Okay. Okay, one more time, guys. Do not leave the cell. Do not leave, because right now everybody's going around the cell and you're going to your head trying to, I want to fit something. No, guys, you have to look at the whole picture. On physical exam, he is lethargic. All right. He's got a temp. Blood pressure's fine. He's a little tacky. And he's got this blowing holosystolic murmur. This is where everybody goes wrong. Now you start, going through your memorization of all the holosystolic murmurs. Stop it. Look at the whole picture. So he's 34. He's an IV drug abuser, right? And I always tell everybody, where do your IV drug abusers live? They live on Staff Island. Staff. What are they shoving through the skin? Staff. So I always say your IV drug users, what are they? Live on Staff Island. As soon as you say IV drug abuser, Staff Island. Where does he live? Staff. What's his dog name? Staff. What kind of car does he like to drive? A Staff. Got it? Made my point clear? Okay. So you see him, he's 34, IV drug abuser, arms twitching, headache. He's got a murmur. He's got a fever. You're like, this sure doesn't sound like multiple sclerosis. This sure doesn't sound like a malignancy. This doesn't sound like he has a, okay, there's your two answers, guys. Stop, step back, common sense, just common sense. You're like, does this sound like herpes or does this sound like an abscess? And you're like, oh, Joe keeps barking about Staff Island. Staff likes to make abscesses. God, I'll have to go with this, Joe. Guys, look how many people chose herpes. Can you please show me in your cell where it says anything that resembles herpes? Just show me. And the answer is, I don't. Exactly. Got it? Got it? One more time, guys. Where do your IV drug users live on? Staff Island. So they give you like the pneumonia, but IV drug abuser. What's he grown? Probably staph. He's probably got a lung abscess. Makes sense, Derek? Come on, guys. You come to work with me if you want to. I'm going to work in a couple hours. You're welcome to come with me. Look at me, all types of IV drug abusers. What's inside that abscess we open up? Staph. So I got a 62-year-old man, presents with fever, headache, confusion, and vomiting for 2 days. Like, okay, that can't be good. His medical history is significant for a liver transplant. Secondary to Wilson, and oh, he's immunocompromised. That's never good. Okay, he is febrile. Blood pressure is fine. Little tacky. He's awake, but he's confused. You're like, yeah, I can get it. Fundescopy, okay, it's normal. His neck is stiff. You're like, okay, so I think he's got meningitis, Joe. Okay, just stop. No, stop right here. You're halfway through the question. Keep forgetting. You got to put your cellmate together along the way. Not at the end, along the way. So he's 62. He's got this fever and he's immunocompromised. You're like, yeah, Joe, he's got meningitis. Okay. So he's got a white count and he's got neutrophils. You're like, yeah, this looks bacterial, Joe. Blood cultures are drawn. Thank you. CT scan is normal. Of course, that was going to be. Lumbar puncture result. Of course, it's going to be. So you have nothing. So you're like, okay, 62. Is he greater than 50? Yes or no? And you're like, oh, yeah, that's right. So listeria is here. So, okay, that makes no sense. Nope, there's no amp. Okay, so there I am. And you're like, wait a second. Joe said vancomycin. Well, there's no Rocephin. Oh, but wait a second. There's the cefepime. Isn't that what Joe says is a good substitute for Rocephin? Yeah. Where's the vancomycin up here? It's not. Let me see this. See how we're breaking this down? I've got a 58-year-old man comes to the office due to ulcer of the right side of his foot. Okay. So he's got an ulcer. The ulcer has failed to heal despite wound care with moisture. Okay. So they're treating it, aren't they? Of course he has diabetes. Of course it's a diabetic foot ulcer. We've all seen that, right? So he's got this 4-centimeter ulcer in the first metatarsal head of the right foot. You're going, okay. One more time, guys. Just stop right here. Just an idea. He's got osteomyelitis. Right, we're all worried that he's got osteomyelitis. Can we agree? Can we also all agree that which bacteria will be fighting? It's like, well, Joe keeps saying it's all staph, so it's staph. But what's in the back seat with my diabetic now? Oh, Pseudomonas. So, and then the wound is cleaned, and at the base is, so you're looking right at bone. There's no surrounding erythema fluctuants. Okay, so you're like, he's a hot mess. He's got bone exposed. He's a diabetic. You're like, well, that makes no sense. Vitamin C and zinc. I don't know what they're thinking here, but good luck with that, right? You're like, oh, that's crazy, Joe. That makes no sense. That makes no sense, right? So this makes no sense. I'm not worried of a cold foot. You're like, oh, this could be the only thing. And just so, right there it is. And then I know you always get this test question, right, that rears its ugly head about this, in other words, the foot imaging, what do we do, right? I mean, what's the best thing for it, right? And you'll see they'll put, regular x-rays or MRI. And what you'll learn, guys, out in the real world is this, is you see, when you got something down to here, I would say, like, when I'm dealing with osteomyelitis, what's the first part of the bone? Let's just say I have a cellulitis, like I got a foot infection, right? And I got a cellulitis. So what part of the foot gets infected first? So, I mean, what part of the bone gets infected first? And you're like, well, that's periosteum. No, exactly. And periosteum is that bone or soft tissue. And you're like, wait a second. Periosteum is the skin of the bone. So it's actually soft tissue. Exactly. So which one picks it up more sensitively. You're like, oh, wait a second, it's the MRI. Exactly. Does everybody see this? Okay, so by the time we see it on the foot x-ray, it's pretty down the road. Does everybody see this? Okay, so now does everybody see the sensitivity of the MRI versus a regular foot x-ray? So I got a 54-year-old woman brought to the ER department due to fever and lethargy, right? The patient has several days of productive cough, okay, developed severe headache, nausea, and vomiting. Okay, so she doesn't sound like she's doing well. This morning, she came weak and confused and could not get out of bed. And you're like, okay, so sums up. She's febrile. Blood pressure is okay. I mean, we can pick this up if you want to. The patient is somnolent, which is like, this is not normal for a 54-year-old female. And she's got a rigid neck. So you're going, okay, I think she's got meningitis, Joe. Okay. She's got crackles in the right lower lung. And see, this is where sometimes people go. So they see these little things that are thrown in the test question, like, and then they get stuck on it. You get it, they get stuck on it. So you're like, okay, let's not get stuck on it. Let's just keep looking at the whole picture, not that one thing. There's no skin rash. Lab shows leukocytosis. Got it. Lumbar punctures. Okay, so she's 54. My cellmate's 54 and a fever and a headache and a stiff neck. Okay, she's 54. So what's the most common form of meningitis? You know, what's the most common form of meningitis after 3 months of age? And you're like, oh, it's strep pneumoniae. Got it. So, and here's the key point. It's like, look how many, does everybody see this? So it's just strep pneumonia. It's just basic facts. And then you're going, yeah, I'd start vancomycin, Joe. And wait a second. She's after age 50. And you're like, oh my gosh, I'm even start something for listeria. Oh, vancomycin. Oh my God, there's the ampicillin. Everybody see this? Okay, a couple more. I got a 5-year-old girl, seizure at home. It's like, okay. About an hour ago, the patient collapsed at dinner and developed, okay, so she went down at dinner. Okay. Her mother states that the patient has had a mild headache and fatigue for the past few days. You're like, okay, it might sound like meningitis or something. On exam, the patient is sleepy and difficult to arouse, right? And that's not normal for a 5-year-old. Any parents out there know, right? Your 5-year-old, that's like nuclear powered, right? Vital signs are normal. Okay. Cardiac exam is normal. And then they put this here. Then, okay, and this is where students go wrong. They go, oh my God, ring enhancing lesion. What did I memorize? Stop memorizing. Put your cellmate together. She's 5. She's seized. Difficult to arouse. She's got something in her head. Which of the following historical details is most relevant? You're like, okay, so she's got this thing in her head. So history of seizures, that makes no sense. Diarrheal illnesses, that just doesn't make any sense to me. Perinatal infection, she's 5, they would have been much sooner. Would you, okay, so here we are. Stop, pull back, common sense. I got either recent head trauma or recent otitis media. And you're like, head trauma cause a lesion? No, it'd be a subdural epidural bleed. I think that's it, Joe. I think, I'm not 100% sure. And we're right. And which the kid's got is a brain abscess, because that, right, that this is what the ring enhancing lesion means, right? If we didn't remember it. But again, this kid grew some otitis media, and guess who's there? Well, let me guess. Most common cause of meningitis is who? Strep pneumonia. And oh, it makes sense to me now. It went from the ear there, right? Does everybody see this? Okay, so just hopefully this makes more sense to everybody, right? I got a 34-year-old man evaluated for the rash on his palms. Okay. He developed knee pain that it says he stands at work. So you're going, okay, so he's got a rash and knee pain. He also has pink eye, and you're like, oh, what the heck? This guy sounds like, a garbage can. We got everything in here. For which he used topical antibiotics that he found in his parents' apartment. Okay, stop and just look at him. He's got a rash on his hands, telling you that his knee hurts and his eyes problem. He's had no fever, lives alone. All you see is, okay, these are pustules. So you're like, okay, so his hands got pustules. He's got problems with his knee and his eye. And you're like, well, that makes no sense. That makes no sense. Tick disease, is this Lyme's? I don't remember pink eye and Lyme's. No, I think this is it. I think it's the only one that makes sense. And you're like, oh, it's reactive arthritis. Oh, they can't see, can't pee, can't climb up a tree. Yeah, there it is. Does everybody see this? Okay, so there's the other rash. You're thinking, oh, maybe meningitis, right? Like, some type of meningococcal something. But he had all this other stuff. Does everybody see we can't leave the cell? That question you're stuck in. Stay stuck in it. And if you do that, guys, you'll do great. It's when people leave the cell, they run into trouble. I got a 32-year-old man comes to the clinic for escalating low back pain. Okay, it's dull, achy, and presents at rest, and it's worth activity. You're going, okay. He recently began using IV heroin. Okay, one more time. One more time, guys. You're an IV drug abuser. Where do you live? Live on Staff Island, Joe. What are you shoving in your skin? Staph. What does staph like to do? Abscesses, please. That's what I like to do. I can put one in your brain. I can put one in your lung. Just name it. I live on Staff Island. So his temperature, okay. Blood pressure, okay. So I don't have anything here. All I got is a guy that lives on Staff Island. Gentle percussion of the lumbar vertebrae. He gets pain. You're like, okay. And a full neurologic exam shows a straight leg raise. So he's got something going on his back, right? So it was normal. I apologize. That's my bad. So you're like, stay in the cell. You don't get to leave. Stay in it. He's 32. He's an IV drug abuser. It's like, that makes no sense. That makes no sense. Where did they, nothing about, nope. So is this a compression fracture? Nope. And you're like, could he grow staph osteomyelitis? You're like, oh yeah, because he lives on Staff Island. Ever see this? 2 more guys and we're done. You get to go enjoy your Sunday. 12-year-old boy comes for evaluation of a limp. And don't go running down the road. Oh, is it, is it this? It's, it's like late cat birth disease. No. Just stay in the cell. Since walking this morning, the patient has not been able to put any weight on his right leg due to the pain. It's like, okay, so whatever this is, it's caused him not able to walk. He's had the pain for the past 2 days, been taking ibuprofen. No, so he's not getting better. He plays basketball and he fell last week during practice and scraped his right hip. Okay, I see him. The abraded area developed mild dilation. Like, oh, okay, so he has an infection on this hip. And they treated him with topical antibiotics. You're like, okay, I see the story. He's febrile now, folks. Everybody see this? On an exam, the right hip is externally rotated and has pain with passage. So there's something in the hip. He's got a white count. You see him now? You see your cellmate. And sed rate is elevated. So it's some type of inflammatory process with the, with the fever and a white count. Ever see this? So you're like, yeah, I think something's going on with the hip, Joe. It's infected or something. Which of the following treatment option would be most beneficial in preventing long-term morbidity in this kid? So you're like, okay, so I got to do something, right? I got to do something, right? So do you want to put him in a cast? Like, that makes no sense. Do you want to shoot steroids in? Like, oh, heck no. Does he need a total hip? No. Do you want to pin this? No. Oh, God, that makes sense. Get the junk out and send it for analysis. Guys, look how many people took surgical pinning of the hip. See, and what I'm trying to show you is just putting the cellmate together. All right, guys, this is it. Last call for alcohol. Here we are. All right. I've got a 68-year-old man, right? So 68, brought to ER due to fever, headache, and lethargy. And you're going, okay, something's up. The patient was previously healthy, so something happened. He is febrile. He is hypotensive, isn't he, guys? This guy's not doing well. Can we agree? You're like, nah. Right? My nurses would be all over me with something like that. The patient is lethargic and only went, so there's something going on here, guys. He can move all 4 extremities. Moderate neck. Okay, so now you're going, I think it's meningitis, Joe. Okay, stop. Look at your cellmate. He's 68 with meningitis. Ever see that? And so everything else, that's all you get. The rest of the question is just fluff. You're like, okay, Joe, so he's 68, right? Mm-hmm. So what did Joe keep preaching to me about? Oh, that's right. It's strep pneumoniae, it's vancomycin, and then when I get greater than 50, listeria shows up and I use ampicillin. You're like, oh, well, that makes sense. Where's my ampicillin? And there you are. Got it? Stuck between these two. And you're going, okay. So there's the vanco, there's the ampicillin. That makes sense. Where's my rocephin? You're like, meropenem? I've heard of the cefepime, but meropenem from that? And let's just say you're a little confused and you're going, God, do we give steroids? Ah, okay. Which one can you swallow? I mean, which one's more palatable to you? The vanco, rocephin, and ampicillin, and I don't know what, or the vanco, ampicillin, and no rocephin. You're like, I can chew this one, Joe. And if you look it up, guys, what you'll see, okay, does everybody see how they chose vanco, rocephin? But what did they miss, guys? He was 68, and who was back in the mix? There it is. Listeria was back. Does everybody see this? Now does this make sense to you? And then what you'll see, guys, if you read the new recent literature about meningitis, is one of the things we're finding out is that these people tend to do better when the meninges is less swollen. And so I know everybody goes, oh, you gave them steroids, so you can immunocompromise them. That's not true, guys. To immunocompromise someone steroids, you got to give it for weeks. So if I just gave a quick dose, just a quick dose, right, to keep the meninges from swelling more and causing seizures, not a big deal, no harm, no foul. And this is what you'll see us do if you come to the ER with us. This is one of the kind of the common combinations. All right, so does that make sense to everybody? All right, does everybody see this? Okay, so as a recap, what did we learn? Right, we learned that in the meningitis, what was it? Neonates, what's going through your head? Group B strep. Who's there? Who's in the back seat? Listeria. What does Listeria need? He needs ampicillin. So I take care of the group B strep, right? That's the cefoxetine. That's just fine, right? So we'll do that, and we'll do the ampicillin. After 3 months of age, I walk the earth. What's my most common cause of meningitis, guys? It's strep pneumoniae. What was my most contagious form? That was the Neisseria. What was my answer for meningitis? Vancomycin, 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 vancomycin. But when did I have to add ampicillin back to the mix, just like the last question, when the person gets greater than 50? Listeria is back. So what do you give them? Vancomycin, and I can use ampicillin. Can I use a dose of steroids to stop the meninges from swelling and causing seizures? Yep, sure can. You'll see, look at the most recent literature, it's all sitting there, right? So this is the right thing. And then the osteomyelitis question. You walk the earth. What's the most common cause? Staph aureus. As soon as they mention sickle cell, you know, oh God, that guy's so immunocompromised. He's like a chemotherapy patient. What's he got? Oh, he's got salmonella. But again, if you and I were to sit down and look at it statistically, who's still driving the car? Staph. Who's in the back seat? Oh, salmonella. He's back here. And then my diabetic, what do? They still grow staph, but what's also there? Pseudomonas. And then how do we treat the pseudomonas? Fluoroquinolones. All right, guys. So hopefully that kind of cleared the air a little bit for you guys and everything. Okay, guys. So listen, it's good seeing everybody again. I hope you enjoy your Sunday Funday, and go enjoy your Sunday, guys. Nice meeting everybody. Take care, guys. Bye, everybody.